Hi guys, here we are for another lecture. And this is basically chapter uh, 13, I believe, chapter 12. A little bit different. It's healthcare organizations and accreditation. So it's going to go over several different things. It doesn't follow your book exactly, but it's close enough. And then there's a few things added in there. So accreditation, what is it? And really more aggressive, what is it? Why is it? So basically, it's a process where you evaluate a healthcare organization. It could be any organization, but in this case, it's healthcare. It measures certain benchmarks and standards. Uh, we do this to assess how the hospital is run so that it can improve the performance and provide safe and high quality care for the patients. So that's what we're looking at. The accreditation is looking at how you go about this and if you actually do it, that you say you do it, but actually if you do it. So some conditions of participation. Really, almost every healthcare facility has to participate in some type of healthcare accreditation. So conditions for preparation is a term, the conditions of preparation is a term that healthcare organizations must meet in order to participate in programs such as Medicare, Medicaid, and CHIP. CHIP is particularly for health care for a child. There's a long list of provisions the hospital must be able to perform. In fact, if you've ever asked anybody about hospital accreditation, it is the dreaded thing because they do everything from checking dust on the top of a wall bucky to looking at your records to be sure they're complete. Hospitals that are accredited are automatically deemed to meet all the health and safety requirements for participation. So if it's an accredited hospital, it says that it has met all these conditions for healthcare organizations. The two places that we see accreditation are hospitals and clinics. There are there are two major accrediting bodies in the United States. It's the Det Norske Veritas, the DNV, which is more commonly called. It's a newer accrediting body. Some would say it's a little bit more exactly focused on actually what is done with the patient, not as much as the periphery things that are done just in the hospital. I think Methodist Hospital is currently using this one. So it focuses on the hospital and the healthcare systems, as both of them do. This is a website if you would like to go and learn more about it. It is an annual award, so it has to be done annually. The other major one that is the older one that most people are familiar with is the Joint Commission, the TJC. It focuses on various healthcare organizations, hospitals. It also could be behavioral facilities, home healthcare agencies, and nursing homes. So it's a little bit more extensive. It has a wider coverage and a little more extensive. And again, you can go online and look at things. If you want to click on this website, it will bring you to that. This is a 3-year award, and the hospital usually works. Even if it's only every 3 years, the hospital has a body that is working on accreditation at all times to be monitoring things and be sure that accreditation requirements are being met and updated so when the actual accreditation comes that you're not in a mad rush to get everything done. So when the TJC or the DNV are in the building, what happens? Well, they visit selected departments or all departments. They may go over medical records. They may interview personnel. They may interview students. So some hospital facilities, Herman this past year when the radiology was going over accreditation, they asked the students not to come. They wanted to be sure that there were not students there that gave a wrong answer or didn't know an answer. I don't subscribe to that being the best thing to do. I believe that you should have students participate. And as this slide says, what is our answer if we don't know? Say, I don't know that answer uh, to that question, but I can find someone who does. You would not be expected to know extensive things, but I believe that the students should be part of that participation. Many of the healthcare facilities do not believe that. So policies and procedures. Every uh, department or every hospital is going to have policies and procedures. There's going to be general policies and procedures for the hospital. There are going to be policies and procedures for each individual department. I'm just looking at a couple of things here. Um, in the policies and procedures, when you get a radiology request or request a radiology, the basic components that we talked about last week are going to be reviewed by the technologist for vital information, the patient's name, their date of birth, their identifying numbers, MRN number and or accession number, usually both of those. Accession number tells the exact number of this exam. If you were doing a foot exam and a hand exam, they would have a different accession number. The MRN, the medical record number, is a permanent number, and it is that patient's number on anything they have done, whether it's lab procedure, a nursing procedure, or a radiology procedure. So that number stays with the medical record number. Um, so the technologist is responsible for this information on there, and that there is a usually that there's a valid diagnosis or why we're doing this and what the exam is. Is it's a hand because the looking for a foreign body in the hand. You have the patient's name, you have their number, uh, maybe how they're traveling, and if there's any special requests like they need oxygen or there are a fall risk or any of those special things. The technologist should look at that. The manager is responsible, even though the management probably doesn't come in and actually look at this, but the manager is responsible to see that the legal and safety measures are all applied when we have a radiology request. In other words, this is not just for a particular request. They are responsible to see that the department has legal and safety measures in place that you will apply to every radiology request. The things that you could do to a patient are the things that you couldn't do to a patient if a patient refuses an exam. All of those things we have written up what the patient's rights are and also the safety measures that an exam is always done by a qualified technologist. That doesn't mean that a student may not assist, but the final okay and the final evaluation of the image is by a registered technologist. We talked about that a little bit today in class. So those are some radiology request things, policies and procedures that would have to do with the request. There's going to be some type of procedure manual. This is going to be in electronic form, or it can be in a paper form. But you may have a manual that has legal forms. The form that might be consent form for a particular exam. What's contained on that consent form? Who has to read it? What exams require a consent form? Every exam does not require a consent form from the patient, a written consent form. A chest x-ray does not have to have a legal written consent form. If you're doing a lumbar puncture in the radiology department or certain other interventional exams, you have to have a legal form that is the consent for treatment, and it tells all the things about that. We're not going over those right now. Their procedure manual is going to have patient preps for different exams. What this patient needs to do, what they need not to do, what would be their time frame on when they do these preparations. The exam procedures themselves. What if you're ordered a cervical spine? What is the procedure that we do, the views that we do for a cervical spine? AP and lateral, flexion and extension, open mouth, swimmers, which ones are included, and maybe at which why some are including, some are not included in other exams. It might be specific, actually, the procedures to a particular physician also, or a particular area of the hospital, but it is going to tell what should be done with each exam. And then there may be something in there in the procedure manual that talks about exam sequencing. If you have multiple exams ordered, which ones you do first? Do you do this one with contrast first, or you do it without contrast first? Do you do this contrast exam where you give something, a barium to drink, or a barium enema, and then you're following up with a CT or an IVP or looking at the urinary system? Which one of those goes first? If you're going to have a nuclear medicine exam, can you give iodine? So it looks at the sequencing and what should be done in which order. And again, I won't go into that right now, but those are all important things that would be in a procedure manual. Human resources also may have something. They're not really in our procedure manual in the radiology department, but they will be in a procedure manual somewhere in the or procedure and policy manual in the hospital, human resources is going to maintain records on the employee. It might have your initial employment. It might have things about your previous employment. It might have letters of recommendation. It might have particular things that private information that pertains to you. Anything else that would need to be known about you. It might even have some health information. The radiology administrator is also going to have a role in the policies and procedures. The human resources may say uh, things that are forbidden or things that the hospital will accept. Whereas the radiology administrator will look at another set of things for policies and procedures. That administrator, whether they do it themselves or someone under them, is tasked with verifying professional licenses and certifications. Not every state has a license to do X-rays, but most of them do. They would say that you have a current license, that you are certified. If you are a certified CT tech or an MRI tech or mammography tech or sonography tech, that your certification is up to date with your continuing education credits. And there's someone that is tasked with that to be sure that every year that your CPR is up to date. Actually, that's every 2 years. That you've had the influenza vaccine. That you have had the TB skin test. So there's someone that's tasked with that to be sure that those policies and procedures of the things that hospital requires, and most of them are the same. And then you may also have work performance evaluations, your yearly evaluation by your direct supervisor, and then it goes on up to the radiology manager. Sometimes your raises or promotions depend on that, on your workforce evaluations. All of this would go under something of policies and procedures of the hospital and of the radiology department. So healthcare organizations, uh, the healthcare organization of modern days runs just like a service industry. In fact, we consider the hospital now a service industry. While it's healthcare, we perform a service to our clients, and many times we call them our clients or our customers now, not our patients. So just like in restaurant, you may hear the patients referred to as customers. I still tend to refer to them as patients because that's what I learned. But I do understand the importance of having them as customers now when patients have much more flexibility in where they want to go. Not complete because their insurance plans may say that they can only go to certain places, and certain hospitals and facilities only take certain healthcare plans. Almost all of them take Medicare and Medicaid, or all of them take Medicare, not all take Medicaid. Uh, the patient is the most important aspect in the imaging department. Well, how can you get around that? The patient's got to be the most important thing. Hospitals exist, healthcare facilities exist for patient care, to care for a patient. Now, sometimes it seems that we lose track of that it maybe seems like we're in the business of doing something else, but that is what the charge and that a hospital should have. So total patient care must be a balance of certain things. Human care and concern, that is where our compassion, our empathy comes in. Technical expertise, we hope that that's what you're gaining here at the hospital. I can't necessarily teach you human caring and concerns. I can tell you some things to look for and some benchmarks I want you to make. Some of that has got to come from internal. The technical expertise, we hope that we can teach you here and get you to that point. And so all of these combine together to give us high quality patient care. You have the technical expertise and you have the caring and compassion and empathy to take care of the patient's emotional needs. The Joint Commission specifies complaints related to it looks at complaints related to patient care, and these must be addressed. So the Joint Commission looks to see if patient cares and complaints are addressed. Part of reimbursement is based on patient satisfaction scores. I talked a little bit about Press-Ganey scores and other things. The Joint Commission is going to look and see how the general patient care experience was. No, obviously not every care, but they will pull patient records and follow that patient all the way through and say, this patient received this kind of diagnosis, it received this kind kind of treatment, it received this kind of aftercare. So it may pull randomly certain patients to follow them through to see that all of these things were met. And if there was a complaint or a concern, how it was addressed. All of that is part of the accreditation process. Since reimbursement is based on patient experience, uh, there are strategies to be implemented, things that we need to do. Follow procedures, that you introduce yourself to the patient, that you have a clean room, that you know what you're doing, that you're efficient, that their time is not wasted. Again, not everything is under our control, but we should have a routine so that we implement the strategies that the hospital is going to have. Because again, we get back to reimbursement. There's marketing and service delivery. Marketing and service delivery are important. The hospital markets itself. You will see advertisements for that, and the services that it can provide. Hospitals are focused on delivering the quality of service that an increasingly demanding public expects. The public expects much more of us than it used to. They There was a time when the public accepted whatever care they got, or they didn't complain. We now know that the squeaky wheel gets the oil. In other words, those who complain or voice a concern usually have their concerns met or at least looked at. So if we look at the patients as a customer, services service as expected by the patient and delivered by the caregiver is the prime factor in patient satisfaction. I expect something, you deliver it. I am probably satisfied. I expect something, you do not deliver it. I am not satisfied. Then we get back to the customer care experience and how they feel about that facility, or maybe not even the entire facility. It might just be about a particular department. Uh, so we can attempt to focus on how to provide our services only by knowing what the public expects about our healthcare delivery. So we should have a good idea of what kind of service we should be performing, what is within our scope of practice, what is not within our scope of practice, so that we might be able to explain that is not a service that we can provide here, so that the patient does not think that they just didn't get a service when that service was not even available there. So consumer organizations regularly interview patients about current issues in healthcare delivery. Their responses are part of the major surveys of the changing healthcare climate. I like that didn't bold that little. I didn't get that little E the same size as everything else. Um, there are organizations that if you go to if you go to Consumer Reports, it will give you certain organizations that have reviewed how this industry did, what the consumer thought about this industry. There are companies that do that just for healthcare. Press Ganey is one of them that I talked about earlier. So why did choose people choose a certain hospital? Why do you choose a certain restaurant? Why do you choose a certain hotel? There's there's myriad reasons why you would choose a particular place. The condition. Does this hospital offer services for spinal injuries or for repairing of the spine or joints? Is it a specialty in obesity and weight reduction? Is it a bariatric hospital? Is it particularly for heart care or for pediatric care? So the condition or the service needed might be one of the choices on the hospital. The proximity. Well, I'm going to choose a lot of things in proximity. If there's two things, one is as good as the other, I'm probably going to choose the one that's closer to me. So we see hospitals expanding out into all the suburbs now that used to just be in the medical center. They want to be in the proximity of their population. Financial. There are We don't get to choose as much, I would say, financially, but you can. There's certain hospitals that cover certain things. There might be a hospital that takes this insurance that doesn't take that one, that takes Medicaid but does or does not take Medicaid. So we based on our finances and what we can afford and what type of insurance we had. The advancements. Or does this place offer the advanced care that I want or the more modern care? And again, Most hospitals fall somewhat in line with that, but there are certain hospitals that are known to have the most state of the art things, and that their advancements and their knowledge. And are they a teaching hospital? Sometimes people want to go to a teaching hospital because they feel like they're more aware and are doing the most current things. Some people don't want to go to a teaching hospital because they feel like they're a guinea pig and being experimented on by people who don't know what they're doing. So that might have a bearing on whether you chose that hospital or not. And then certainly emotional. I was born in this hospital. My grandmother died in this hospital. Uh, I had a friend that helped design this hospital. You may have an emotional attachment for a particular place. I had an emotional attachment for the place that I trained. I felt like that it was the best place. I don't know that I had done a true evaluation, but there were people that I knew and loved there. My relatives were treated at that place, and so I had an emotional attachment to that. So I would have chosen it over another hospital in the city based truly on that and not looking so much at some of these other things. So there could be various reasons. We, whichever hospital that is, not necessarily us in particular, that hospital wants to capture as many of these things as we can so that the patients continually choose that hospital. Patients are increasingly indicated. Patients are increasingly indicating quality of patient care as a crucial choice in their healthcare providers. You will hear people all the time say, I wouldn't go back there because I didn't feel like I got good care. And it may not be that the medical condition, but it could be from help to go to the restroom, the food, or just the general attitude or the cleanliness of it. So they look at that. So surveys indicate a strong reliance on word of mouth advertising and peer recommendation when selecting physicians and hospitals. Again, I can go back to that myself. I had a knee replacement. I asked the X-ray technologist in the department who they would recommend that when they saw the orthopedic surgery, what doctor they would recommend. They recommended a particular doctor, and he was at a particular hospital. So I chose that doctor and that hospital based on word of mouth because I trusted these guys because they work with him every day, and I've been very pleased with my trusting. So probably all of us know people that we wouldn't want to do our plumbing, our car repair, our roofing, our just electrical work, and there may be people that we depend on. So good advertising by word of mouth can't be beat. Uh, However, information gathered from research in the internet is the most common source of healthcare information. I don't know that I would agree that it's the most common, but there are people that really want to do their research not by their friends or their relatives, but they want to do research and see what maybe an independent organization has rated a healthcare facility. Uh, uh, Staff courtesy is identified as a very important factor in patients' initial choice of a hospital and their reasons for returning to that hospital. That is such a true statement. I don't care if they medically got you well, if you felt like that you did not have good patient care, that people didn't listen to your concerns or they were rude to you, maybe I could say that I can get that same level of medical care, but I can get it from a more professional, caring staff, and so I will choose another hospital. So all of these things work together for the patient. Some food for thought. What are the reasons you go where you go? We just talked about where you go to a hotel, whether you go to a restaurant. Uh, so if we apply those to healthcare, have you needed healthcare or emergency care? If you have, then you probably have an opinion on some of the places you've been to. What are the best reasons, in your opinion, to choose one institution over another? Again, it may be me because it's proximity. It may be you because of the advanced qualities that they have. It could be someone else because of that emotional state. So, do the employees and the manner in which patients are treated have an influence on your decision? Should it? I would venture to say that most people, it does have some bearing on their decision to go there. And yes, I think it should. I think that's an individual choice that you have. Sometimes you're forced to go back to a particular place because of the care that you get, that specific care or that specific doctor, and yet you don't particularly care for them. I hear that all the time. I believe that's a good doctor or a good hospital. I just don't particularly like it. Well, if I wasn't already involved in that and someone hears me saying that, they might make another choice. So I would say that yes, the manner that you're treated by the staff, going from housekeeping all the way up to higher management, does make a difference. And yes, I think it should make a difference. But that's for you to decide. There's two things we talked. The book talks a little bit about inside and outside customers. Outside customers are patient, family, referring physician, and community. So the patient's family may want you to go there. The referring physician may have you go to a particular hospital because he has privileges there. That community may inspire you to go to a particular hospital. So these are the outside influences, the outside customers. The inside customers are members of the other departments within the healthcare institution. So we've got to look at the people that we work with inside and the people that we work with outside. For our customers, so we want to have good relationships with these outside people. We also need to have good relationships with the inside people for our department so that departments function and manage and depend on each other. So inside customers. When we realize that we serve inside customers, the work environment becomes more cooperative. It is important that I have that inside customers may be lab, it may be patient transportation, it may be admitting. If you don't work closely with them, then your job becomes much harder. We are as responsible for providing high quality service to each other as we are providing it for a patient. And when they say high quality service, that may not mean that you're doing an X-ray on somebody from that department, but that our department cooperates, provides its service, that it gets its reports out, that it does its patients in a timely manner, and so that it facilitates the entire patient care experience. All departments are striving to heal those who come to them. We must work together with support and cooperation. We can't do the entire hospital job without all the other departments. So it is important that we work with what we call our inside customers. Our outside customers, then, those are the people that we're going to be, this is going to be coming in where our revenue is coming from. Everyone in the community is an outside customer because we're not pleasing them as an inside person. They're the person who is coming to us for that medical service. We focus on the patients and their families as our primary outside customers. They are the ones who come to us and place their confidence in our care. The physicians who practice at our facility are important outside customers as well. They admit their patients because of our expertise. These physicians also deserve the best of our services. There are physicians that won't admit to certain hospitals because they don't like the personnel or they don't think the quality of care or they may not even think the quality of radiology is very good there. I've heard certain doctors say that they don't believe that if they get radiographs that come from a certain place that they don't trust them or they don't think they're very good quality radiographs and may have them repeated at that facility. So many others from the outside come to our facility on a regular basis. These could be suppliers, delivery personnel, clergy, or sales and service specialists. So there's a bunch of people that may not be our direct paying customer, but yet they're an integral part of of our hospital in making the place run. Although they may not be customers as such, members remember that they spread our reputation by word of mouth and should be regarded as important links to the community. We should always be considerate of everybody we see in the hospital, whether they're our direct patient or not, because you never know who is visiting the hospital. But even if it's somebody important or not important, it is our responsibility to treat everybody that comes there with respect. They also should respect our facility. I agree to that. So the moments of truth, patient's basic reaction to an event. It can be small or it can be large. Your perception or the perception of these guys skydiving may be quite different. It may be old hat for some of them. It may be a brand new experience, and that's the same thing for healthcare. Um, your reaction can be small or large. The thing that seems like a small event, somebody may get very upset over, and something that's like a major catastrophic event, they may accept it without much fanfare. Patients form opinions based on their perceptions of the event. You had a good understanding of the event. It was unpleasant, but you knew what to expect. people made you feel comfortable, people were empathetic, then even if it was a bad event, their perception of how it was handled makes a difference. Your perceptions can be both positive and negative, and every patient is going to bring in their own filters from their past experiences, from their knowledge of what they expect, and just their own person. So each person is different. Basis of excellent customer service, we have to look at that and try to provide for each person from where they come at that point. This is just talking a little bit about the radiology organization. Uh, every place is going to have an organizational chart. This our department has an organizational chart. I'm a instructor. Ms. Salazar is the clinical coordinator. Mr. Daza is the program director. Dr. Jeff Griccar is our dean. Dr. Harrison is our president, and our chancellor is Margaret Ford Fisher. So we have an organizational chart that moves up. Every place is going to have one. Basically, every hospital is going to have a board of directors. There's going to be somebody that's the CEO, the chief executive officer. They are going to who quote runs the hospital, but they will be governed by a board of directors that is appointed and sometimes elected and selected. It's according to how the hospital is set up. If it's a county hospital, they may be elected. If it's a private hospital, they may be appointed. If it is a government hospital, they may operate differently. So there's the CEO. Then there's usually, and this is going to be a pretty basic one. There's going to be a CFO, a chief financial officer, that looks at how the money things are run, how money is spent, how money is brought in. Then there's going to be a chief operating officer that is going to see how does day-to-day operations. Well, that person may not, but they would be over the people that see day-to-day operations of how the hospital is run. We have a person uh, we have two people here that are over facilities management here. They say that we run, they don't teach, but they see that the facilities are heated, cooled, that they have all the services that go with them. So that's going to be part of the chief operating officer to be sure that things run. Then if we skip down, then each department, I've just gone to radiology, but each department would also have a director or a supervisor. So if we have the director of radiology, and I've just listed some here as your book did, there may be other divisions, but the radiology director may be over all imaging services, and there might be a supervisor over CT, MRI, and mammography. Herman Hospital inpatient does not have mammography. Their supervisor, their MRI supervisor, is just over MRI. The CT supervisor is over CT because those departments are so large. But the other another supervisor and diagnostic radiology has its own supervisor. But in Herman, that nuclear medicine and ultrasound are under the same department, and IR may be under CT. So they may not always be divided up like this, but there's usually several supervisors that are over certain diagnostic tools. There's going to be a supervisor over office staff. This may be all the administrative staff, the intake people. It may be over transportation. It's going to be somebody that is going to look at how the things are run, not by the technologists that are doing the exam. And then there's usually going to be a PACS administrator that's over how all the pictures are stored and communication with all the images. Under them, then there's going to be the registered technologist, whether they're CT, MRI, or mammography. That supervisor is going to have the diagnostic technologist, the nuclear medicine, the interventional radiography, and the sonography techs under them. And so this supervising office staff transporters, they I don't like the word non-professional staff. They are not medical professional staff. They may be professional in something else. They in their certain areas, but this should really be as better said as non-medical professional staff. But they perform a valuable duty. And then the PACS administrator usually is going to have registered technologists under them also. They will have some of this, maybe this non-professional staff, but they will have registered technologists over them. So technologists under here and registered technologists in the various fields under here. Reimbursement, important. We can't run the hospital without money. I went online and pulled these couple of things: how the hospital gets its money, how it's reimbursed. There's private health insurance. Those are usually employee sponsored health insurance. In the United States, that is our biggest form of health insurance, is through employer based. It may be based on how much you work, the number of hours you work, how many people are in that organization. So the most common coverage where employees provide health insurance to their or employers provide health insurance to their employees. There's individual plans, people who can also purchase health insurance directly from the insurance company or through a health insurance marketplace. The health insurance marketplace is going to be referring more to that Affordable Care Act. But these individual plans, these are usually people with plenty of money. When I worked at MD Anderson, we saw quite a few patients from the Middle East that were coming for cancer care. They brought cash, or they brought their own money. They were not under a health care plan. They had plenty of money. They paid directly. And we'll talk more about that marketplace in just a second. The government programs are Medicare and Medicaid. Those are the two big ones. Medicare became in existence in the 1960s, a federal program that primarily served seniors age 65 and older. It also serves individuals that might have certain disabilities. So it has grown. It is a huge expense for our government, but it was a needed expense for our government. In the early stages, it was not well, I won't say it wasn't well regulated. The way, well, we'll talk about that in a second, the way that hospitals are reimbursed and used Medicare. Medicaid is a joint federal and state program that provides coverage for low income individuals and families. It's gets funding from the federal government, but each state decides how much and how it will administer those Medicaid funds. The state of Texas has chosen not to use Medicaid in some forms, and we have the lowest rate of insurance. And I'm not just saying that, you can look this up. We have the most uninsured people in the state of Texas of any state in the union, the highest percentage. The Affordable Care Act was passed in March of 2011, and it goes back to, it's somewhere between government program and a personal insurance plan. There is, you pay because you don't have an employer. You pay out of your own pocket money for the Affordable Care Act. But these health insurance marketplaces, based on your income, based on where you live, based on several factors, you may get a subsidy or a discount from the government because you meet certain qualifications. One thing about the Affordable Care Act, it provided coverage for people with pre-existing conditions and other provisions, maybe on a child up to being on your plan until you're 26 years old, or being able to not deny coverage on certain basis. So the Affordable Care Act looked at some of those things also. And then there's the purely out-of-pocket payments. Well, out-of-pocket payments, even for if you have a sponsored, health-sponsored, employee-sponsored insurance plan, almost everybody is going to have a co-payment, a deductible, or a co-insurance. These are payments that are made at the time of service. Like anytime I go in, to my doctor, I am going to have a copay. Except for once a year, I get a completely covered uh, physical for that year. Uh, and people without insurance may cover their full cost directly. This refers back up to these if you have an individual plan, or if you don't have any plan and you just pay for out of your own pocket because you've got plenty of money. Medicare, again, 1965, federal government began offering Medicaid for older adults, Medicaid for low-income persons and families. These programs were established with a cost. They were established originally on a cost-basis system for reimbursement. In other words, if you did this exam, you got this much money. Which you can see if there was no incentive provided to control cost. So this open-ended reimbursement system, in effect, rewarded you. Well, if I get paid for doing this many tests, then I will do more tests. If I get paid for doing this many operations, I'll do more operations. So in effect, it promoted people to abuse the system and not make it as efficient as it could be. Medicare, the concern and public outcry over these runaway health costs was great. It still is great. There's many people that have issues with how Medicare is run, and many of them legitimate. There have been much fraud under Medicare, but also Medicare has been a literal lifesaver for a great population in the United States. So under the old system, payments were limited. Under this system, payments are limited to a set amount allocated to specific diagnosis. This is under the new one. Under the old one, under cost-based reimbursement, a hospital could spend $1 and be assured it was getting part of that dollar back. So it knew that it was going to get some money back. Under the new system, a hospital has the opportunity to make $1 by saving $1. If they say this person has this diagnosis, and if you can successfully get them well and out of here, then if you don't have to do all these tests, if you don't have to spend all this money, then you are going to be paid for how well you do on that exam. On the other hand, if it says that it will pay this much for a urinary tract infection or this operation, and the patient gets an infection while they're under your care, it may not reimburse for all that. So the hospital can lose money. So it incentivizes the hospital to make their care appropriate and quality. It should be anyway, but it's just a different cost reimbursement system. It's just not for every test you do, I will reimburse you. This is usually for a condition, a medical condition coded. So the radiology department moved from being a profit center to a cost center. In other words, used to look at it as a profit center. Now it's how much does it cost to run that department, even though we are still a great revenue source for the hospital. So the economics of radiology, revenue generating departments in the hospital are radiology, laboratory, and pharmacy. These bring in the money for the hospital. I can't put a charge on your bill for sweeping the floor or for the cafeteria. Those are quote built into the system, but there are direct charges for radiology, for laboratory, and for pharmacy where the hospital can make money. Radiology is one of the most expensive hospital departments because we have a vast personnel and we have expensive medical equipment. We run 24 hours a day, 7 days a week. So it is one of the expensive departments to run. On the other hand, it is a very much of a revenue generating department for the hospital. So things we can do to increase our resources and be better stewards of the money. When we're better stewards of the department's money, then we can hire more people or it can hire more people and give more raises. Repeat exams, I don't really know what it meant by that when you look into that. When there was a time when we had to repeat exams, when we were buying film, that was a great consideration of the cost. Where I trained, uh, the repeat rate was a great cost because you spent money on every single film that you used and the chemicals to process and the keeping the processor running. So that was more of a expense. It might be more of a time expense now than a pure expense that you're making. Scheduling exams for maximum unit, equipment, and personnel use, that makes sense. You want to buy equipment that is going to be utilized frequently. A piece of equipment sitting there not being used is not generating any revenue, and yet it costs money to buy, to maintain, and keep in working order. And so it is important that exams are scheduled correctly, and maybe sometimes almost even overscheduled for the patients that don't show up. On the other hand, you schedule exams and one exam takes twice or three times as long as you thought, and the schedule is off. So scheduling is important, but it can be a real problem. Anybody who works in an area, if you've been at some of the hospitals or if you've been a patient yourself, yes, you have a scheduled time. The doctor has to be out because something happened. He has to go to the hospital. Their patient had a problem in front of you and it took longer. So scheduling is an important thing, and there's a science and a art to scheduling. I don't know that I have that, but people have done studies on that, how long it should take, and so the scheduling is done that way. Practice conservation and the use of materials and supplies in all areas. That just goes to make sense. We should be good stewards on our own home, for the environment, for economics. If you don't have to use something, don't use it. If you don't have to throw something away, don't throw it away. If you can get by, and I don't mean cutting corners, but I mean legitimately, don't do things or waste material or supplies that you don't have to. because the money you save is going to save the department money, and hopefully it will come back around to the department having better services, better equipment, more personnel, and possibly higher salaries. Staffing is the single most important cost of the hospital, because there's got to be technologists, there has to be maybe radiologists employed by the hospital, the auxiliary personnel that keep records, that move patients. All of these things go into the radiology staff. Again, I think I didn't when I was doing increasing the size of this font. I missed a couple of letters. So the radiology staff is the important part of the hospital labor force and cost. Because not only did they pay your salary, they usually have benefits. Their sick time and vacation time and health benefits, and maybe other things also. Maybe time off for maternity leave and for those kind of things. So there's administrators in the hospital, there's RT, there's the clerical staff, support staff. Clerical staff is going to be record keeping, those kind of things. Support staff could be anybody from transportation to cleaning, all of those things. And then the medical staff is going to be the doctors, uh, that other people that are not RTs, that are medical support. The nurses also. There's nursing staff in the radiology usually. Equipment is the most expensive capital item. It may cost $1 million or $2 million for a new CT machine or a new MRI machine. These scanners are very sophisticated and they're very expensive. So there needs to be an analysis of need. Does the hospital need to buy a new piece of equipment? Does it warrant it? Do they do enough of these exams? Maybe it's an exam that could use this piece of equipment, but you do it very seldom. That hospital may deem that the analysis of need is not there for that piece of equipment at this time at this hospital. Maintenance contracts. Every hospital that has a big piece of equipment is going to have some type of maintenance contract. They can't afford to let a machine be down. When I worked at MD Anderson, it almost had exclusively GECT equipment. It had so much GECT equipment that GE furnished a technologist or a maintenance specialist that worked for GE that just serviced MD Anderson. When another hospital, when Siemens, I think it was Siemens, was wanting to sell equipment there, the hospital wanted to know, can you provide us with a dedicated service engineer? Well, the answer was no if you just have one Siemens unit. And so effectively, they kept buying GE because GE had a service technologist there because they had lots of GE equipment. The other equipment, if you just had one or two pieces, they could not provide a dedicated service engineer, so the hospital shied away from that. They've gotten away from that some now, but a hospital is going to look as their how accessible and how quick that they can get a service engineer, and with a maintenance contract, usually that comes easier. Thinking in the terms of the life cost cycle of the equipment. uh, how many exams, how much revenue can this machine bring in its life cycle? And there's a projected life cycle, just like we have projected life cycles for insurance companies, how long that life insurance that they project us to live. They make their analysis on that. I forgot what I forgot what the name of that chart is. Uh, it's based on the general population, how much you're gonna live. So you also have to look at the cost cycle of the equipment, how long it's going to last, and how much revenue it can bring in. And